This episode was brought to you in part by Audible. With nearly 200,000 ad-free audiobooks, I'm sure you'll find something you'd like. I recommend Brain on Fire by Susanna Cahalan. It's the story of a Washington Post reporter who describes in vivid detail her battle with anti-NMDA receptor encephalitis. To hear this book and get your free 30-day trial, go to audibletrial.com/brainwaves and sign up. The first month is free and less than $15 a month for each subsequent month, with no cancellation fees. So take a minute to sign up for free at audibletrial.com/brainwaves.
When I was a medical student, I met a mother and daughter who had been receiving treatments at a Lyme Infusion Center.
This is Dr. David Doe. He's a neurologist in Philadelphia.
And to some extent, it was almost therapeutic to them. It offered them an escape, and they would go drive into some part of rural Pennsylvania and get these weeks of infusion therapies. And while it was probably pretty expensive, they seemed to find therapy in that process. Unfortunately, upon evaluation, we actually had some evidence that the patient may have had a real condition, may have had lupus, but they actually had a hard time accepting that diagnosis. And in fact, I'm not sure that they pursued management of that condition in favor of the diagnosis of chronic Lyme. I think that these conditions like chronic Lyme and like fibromyalgia and multiple sclerosis, they're often real conditions, or they are real conditions, but a large number of people have really clung on to them, and the diagnoses mean a lot to these people, even if they don't actually have them.
In addition to being a neurologist, Dr. Doe is an app developer and an entrepreneur, and he's a good friend. Thanks so much for joining me today, Dr. Doe.
Thanks for having me on your show.
In 2011, you and a friend of yours from medical school founded Symcat, and this is an online smart symptom checker that's helped patients and physicians build differential diagnoses based on a constellation of clinical symptoms. Just tell our listeners a little bit about that program.
I started Symcat with a classmate in medical school, and at that time, we were trainees and we were trying to learn to develop differential diagnoses. And it started really as a way for us to have assistance in developing differential diagnoses. And eventually we had the idea to try to commercialize this, and it seemed natural that the consumers would be people who are non-medical professionals. And we were actually, in one Harvard study, ranked as the most accurate symptom checker on the internet. But it's still a long way from a real medical opinion.
But turning a symptom into a risk factor and translating that risk factor into probabilities was no simple feat. And apps like Symcat no doubt have helped people learn about their bodies and their well-being. But now that we're knee-deep in this open data movement, when information is freely available regardless of its authorship or its accuracy, where do you draw the line between a wealth of expert medical information and an incontinent surplus of erroneous opinions? How does one distinguish safe from sorry when using social media? Welcome back to BrainWaves. I'm Jim Siegler. This week, how the open data movement has impacted and will continue to influence healthcare. Medical care is no longer about the private patient-provider experience. Applications like Symcat and sites like WebMD have existed for a decade or more by now, and these have digitized the basic data overlying patients' health, which is actually kind of spectacular for a lot of people. So, Dr. Rodman, let's pretend like you've got a mild headache and a low-grade fever.
Oh, I have. Well, if you're one of my patients, it's probably TB meningitis.
That's Dr. Adam Rodman. He's a friend of mine from med school and also host of the medical podcast Bedside Rounds. More on that later. So how's your headache, Adam?
Oh, yeah. So my headache it's bilateral. It's been going on for a few weeks. I just feel hot all the time. Sometimes I take my temperature and it's like 99.5, but I run low, so 99.5 is a fever for me. Yeah.
Yeah, we see that. I'm sorry to hear about that, Adam. But instead of going to your physical doctor, you paged Dr. Google, you looked up Dr. Google to get a quicker answer.
So I'm going to Google headache and fever. Headache and fever.
And as a patient, you do this all the time. But how often do you actually do this as a physician, to be honest?
How often do I go to Google to get an answer for my patients? I use Google all the time.
I totally agree. And for patients, I think these automated programs and web pages have now empowered you to learn about your symptoms.
Yeah, Google Scholar is a great resource, and quite honestly...
I'm going to take a moment away from Adam while he talks about Google Scholar. For patients, these automated programs and web pages like Google Scholar have empowered the patient to learn about their symptoms. Maybe Adam's just got a touch of the flu, and services that he finds on the internet have now given him the tools to act on his symptoms without waiting in line for a doctor's visit. Drink plenty of fluids and take some Tylenol, your phone or your app says. Because of this quick and easy fix to a most likely benign problem, who would want to drop a $50 copay at their primary care physician's office when they could spend just a few minutes of their life on the World Wide Web? But even this digital environment has its own limitations. Here's what Dr. Doe had to say.
We have limitations on how well you can characterize a symptom. It's easy to say that I have a cough, but it's not easy to tell a system that I've had a cough for 2 years that's become worse in the past 2 weeks, and the timing, those characteristics are very important in a diagnosis. And not to mention the fact that a system like this may be okay at diagnosing a new condition or differentiating the flu from a bacterial infection. A lot of the medical need out there is based on chronic conditions or medication management or side effects of medications. And so it's very limited in what you can do with a system like that.
And now there's been a movement to kind of integrate more providers, more humans into a patient's care. And for as long as I've been seeing patients, seldom has there been a time when it's just me and the patient. And Dr. Rodman, you can corroborate this. If you've worked with a patient in an outpatient clinic or seen a hospitalized patient, you know that you're not just treating the patient. You're treating an entourage. You're treating the patient's husband, the patient's wife, sons, daughters, cousins, best friends, old friends, doctors, lawyers, and so on. You're on the phone with me from Botswana, which is pretty crazy. When you see a patient in Botswana, how many family members come with that patient?
The culture in Botswana, the expectation actually is that you treat the family. Family is always at the bedside, and if you are doing anything, you tell the family, and often not even with the patient in the same room. So very, very family-centered culture, so even more so than the United States.
And I'm assuming that because the family has come to see you as well, these family members aren't even medical authorities, right?
No. They're people who love the patient and care about the patient and are part. I mean, sometimes they'll just be friends or distant relatives, but they are advocating for the patient and they want to do what's best for them.
Sure, for sure. But still, it leaves you with you as the provider who's forced to weigh those opinions and the expertise of those family members along with the patients. And they've probably done their own research, or they've asked their own friends or other family members about causes of headache and causes of low-grade fevers.
Yeah.
Or maybe they use an app like Symcat, or maybe in the Western world they've tried to access more internet, but I don't think that they necessarily... Would you say that they do that?
No, not in Botswana. Actually, in Botswana, it's interesting, the headache example, they come with a cultural knowledge that is very different than ours. So you probably do LPs all the time. Probably your patients don't say no frequently. But in Botswana, there's the 5-10 years ago, AIDS is still very prevalent, but it was far more prevalent than it is now. And people would get LPs and they would die soon after. And that's kind of this kind of cultural experience that people bring, which is similar. I mean, it's a shared cultural experience. It's similar to Googling or to to bringing your own experiences with disease to the table.
And honestly, and that makes sense. So the family and their friends know now, because of whatever they've discussed or because of their cultural background, that something is wrong, and maybe they think it's a brain tumor, or in Western countries they may think that maybe this is meningitis because that's what they saw on the symptom tracker, or maybe this was an intracranial hemorrhage, and they want you to test them for all of these diseases. And this is definitely physically and economically more challenging to do in places like Botswana, where you don't have the same access to resources. And in the US, it's not as easy to do because it may be morally unjustifiable to do, where risks of these tests and maybe treatments outweigh the benefits.
Yeah, so this comes up less in Botswana than it did in Boston, but this is always very challenging.
And Dr. Doe?
I think that we as specialists, we have the tendency to send every last test. And, while that probably makes sense because it ends up being testing that people do, at some point we might be contributing to the harm by doing more testing. So, I think it's important to have some perspective and be willing to take the time to counsel the patient in some of these cases where there's an exceedingly low probability that any testing would give an answer.
All the while, you as the clever physician, you're trying to be conservative. You're trying to avoid unnecessary and sometimes risky diagnostic testing, but the patient is also becoming more and more clever. They're finding that their entourage extends beyond the walls of that clinic room and beyond that hospital corridor. In recent years, the list of these kind of clinical contributors no longer ends with the people that you know.
And a diagnosis could take months or even years to come through, which is why some are posting their medical histories on sites like crowdmed.com, asking strangers for possible solutions to their unanswered health questions.
As the website's name suggests, crowdmed.com actually refers to crowdsourcing medicine.
On the website, anyone can post solutions whether they have a medical background or not.
Although that news report was only a few years young, the term crowdsourcing is actually a pretty old concept. And by old, I mean old in computer years. It was introduced 12 years ago by the editors of Wired magazine, Jeff Howe and Mark Robinson, as a business method for distributing occupational tasks as part of the open data movement. In their words,
crowdsourcing represents the act of a company or institution taking a function once performed by employees and outsourcing it to an undefined, and generally large, network of people in the form of an open call. This can take the form of peer production, when the job is performed collaboratively, but is also often undertaken by sole individuals. The crucial prerequisite is the use of the open call format and the large network of potential laborers.
Let's consider an example here, the mobile app Food Switch. Now, this app was created by a group in Australia, and basically it provides nutrition information about specific kinds of foods.
First cayenne hot peppers.
Mostly those found in Australia.
I'm going to start on the kangaroo. I'm a big fan of using kangaroo. It's a really lean meat. It's good for the environment.
It uses a crowdsourcing approach, like what we're talking about, where users can request to add new food items to the app. Bear in mind, these users don't directly input the nutritional information. They can't just log in and say, I think broccoli is chock full of carbs. There's a data management center that actually runs the show and confirms the nutritional content of food. And that's pretty innocuous, right, Adam?
Yeah, I mean, no one is going to hurt themselves with this, and it sounds like people generally have an idea about what foods are good for them, so I can see why this logic would work.
Now let's step it up a bit. Instead of utilizing crowdsourcing as a means of identifying the number of grams of fiber in a kangaroo, let's say you use it to identify all the available defibrillators in a country. A woman finds a defibrillator at the local market, she opens her defibrillator app, and she logs the location of the defibrillator at 49th Street in Maine. It's basically like using the Waze app, but instead of identifying speed traps, she's tagging resuscitation equipment.
I think that's brilliant. It's a low-resource intervention that can save lives.
Have you ever heard that this is done?
Yeah, I'm assuming you're going to tell me the name of the app. There was some press about it a few years back. What's it called?
I forget what the app, it's like called Pulse Point or something like that. And since then they've actually developed other apps in other countries. And even in Philadelphia, actually, like that was the second site in Philadelphia. So this exists out there. But without any kind of monitoring, how ethical or justifiable is it to have some unknown source tell you that there is a defibrillator here when in fact it could actually not even be a defibrillator? It could be a first aid kit, or the defibrillator could be there but it's behind a locked door or in a closed office building and you can't access it. That has the potential to really devastate somebody's life if you're relying on that type of information when it could be false or inaccurate.
Yeah, that's true. I think this is tricky, right? Crowdsourcing bathrooms, whatever. The worst case scenario is you have to hold your pee a little bit longer. Crowdsourcing defibrillators, the worst case is you die of sudden cardiac death and you don't get a shock. But to me, it has to be judged against the alternative, which presumably is that there is no source of information. I see the ethical standpoint, and the only way that it would be ethical is if it is better than the alternatives. If the alternative situation where we don't have any information would be worse than crowdsourced information. What do you think about that? What's your opinion? Do you think it's ethical to crowdsource the location of AEDs?
I think so. I think that my concern is really in the type of monitoring and surveillance of that information. I don't think that it's fair to the user to be able to open the app and see that there are defibrillators all over the place that some rando has put in, or some prankster is on the other line and just says, what the hell, like this is funny, So I think that as long as there is some sort of monitoring or surveillance or peer review, then crowdsourcing for this kind of information is super helpful, and there's no doubt that it can save lives if it is monitored in some sort of way. So I would say that rule number one with crowdsourcing in medical care is it must maintain a peer review process.
How can we solve the problem of ubiquitous misinformation?
That's a good question. I'm not really sure. I think that misinformation is not isolated to health information. And I think a lot of people who are roaming the internet to find an answer are desperate. And you can tell on sites like Patients Like Me that a lot of people have chronic conditions, a lot of chronic pain. Something that's been showing up on my newsfeed recently is a chronic Lyme page where they're trying to sell products that are not at all proven, but given to patients who are suffering from what they think is chronic Lyme disease. So, unfortunately, I think that because there are so many people out there who are desperate for an answer and will take almost any answer, I think it will be hard to eliminate a lot of the misinformation.
Now let's consider another clinical scenario, Dr. Rodman. Remember you were having a mild headache and some fevers a few minutes ago? Dr. Google said that you had the flu. So what'd you do about it?
I drank lots of water and took some Tylenol, like Dr. Google told me to.
Did you see your primary care doctor?
Me, personally, Dr. Adam Rodman is the world's worst patient and will treat himself without going to anyone else. But the hypothetical patient, Adam, would go see his doctor after his self-treatment failed. Okay,
and so now you're talking to me because you're still having your headache and your fever, so I presume that your doctor didn't really help you.
No.
So you still have the symptoms, you're unsatisfied with your care, you scale it up a notch, and you try to find out more information than what Dr. Google can provide. You go to a website like patientslikeme.com or CrowdMed or a dozen of other sites that can give you answers from people themselves, not just from computer programs. And now you're crowdsourcing this clinical complaint. Instead of getting potentially misleading information or misleading answers from a digital database, you're actually querying people who may have had symptoms like yours. And it makes you think of things like, do I have meningitis? Do I have encephalitis? Do I have TB? because I'm in Botswana, and everybody in Botswana thinks that they have TB because they probably have TB. So you're asking yourself, do I have Lyme disease? Maybe. I mean, you might have Lyme disease that can cause fever and headache. So now you're going to engage in one of these chronic Lyme disease survivor groups, and you're trying to gain some intel about your condition. You want to see what works, what doesn't work, and kind of figure out the next course of action. The problem is when you access these unmonitored sites or apps, you may be getting opinions on your headache from a dozen experts, and you may be getting opinions from a dozen quacks, and that can be really misleading, just like having the false information from people putting up defibrillator locations on Pulse Point. So, is there anything better that patients can use?
Right. So the logic would be take the wisdom of the crowds and apply it to physicians, or I should say medical professionals of all stripes.
How would that be different from the way you acquire information from patients?
There's a couple ways in which it would be different. One, I am having expert opinions. So Google, very smart. Actually, it's gotten pretty good at giving accurate health information, but it is not thinking critically. Patients are going to have, what is that bias called where you're biased by your own experiences? Cannot remember right now. I don't know, this tunneling bias. If you're approaching a support group, they're all going to have experiences with what they've gone through, and they're going to tend to see the world in that way. So theoretically, physicians won't have that bias. But then the third way that it's different is that in my opinion, there may be it may be ethically fraught for physicians to participate in this. Right? There's ethical obligations that are not present when you're Googling something, or when you're asking, a support group or people who have similar symptoms or similar diseases for help. You would have to have a system in which physicians were rated not by patient satisfaction, but becoming to an appropriate diagnosis that was confirmed in some way, right? I mean, people are going for an accurate diagnosis, and you'd have to have some way to confirm that doctor is actually making the diagnosis and not diagnosing chronic Lyme disease or adrenal fatigue.
But a lot of these patients come onto these websites knowing what their doctors have told them, from a neurologic perspective.
You have an etoposide neuropathy because you've been treated for your prior Hodgkin's lymphoma, and it's not going to get better because it's been 5 years and you're just not improving.
But patients don't want to hear that, because they want to hear that there's something that's reversible. They want to hear that if they take ginseng or ginkgo biloba or they do tai chi, that they're going to start feeling on their toes again and they're going to be more balanced. And if you're that doctor who says, why don't you try to drink Thai tea, it's going to help you feel better. You're going to get a positive response from that patient. So, knowing that there are complications and potentially errors, and there are biases, like even the bias you mentioned, in decision making from the physician's end of crowdsourcing, do you still feel like crowdsourcing in medical care can be effective for patients?
I am a firm believer in evidence-based medicine, and I think that's an open question, right? I do know that there's active research going on to see if crowdsourcing diagnoses is effective, and I can see how it could go horribly wrong, but I think the book is open on whether it works or not, at least until there's data published about it.
And I think that this really goes back to your point earlier about, is it better than the alternative? It would be interesting to actually compare patients who go onto crowdsourcing sites like crowdmed.com and compare them to patients who go onto websites like patientslikeme.com and patients who don't, and just see, is a patient more likely to obtain an accurate diagnosis more quickly, or to begin treatment more quickly, or sustain greater improvements compared to those other groups. And in a lot of disorders in neurology, for sure, I'm not as familiar with the medicine information, but definitely in neurology, there's so many delays to diagnoses that it really has the potential to negatively impact care. I mean, the average time to diagnosis for, amyotrophic lateral sclerosis is almost 15 months, which is crazy because these patients die within 3 to 5 years, even with maximal medical therapy with riluzole. The average duration from symptom onset to diagnosis of non-epileptic seizures is like 7 or 8 years. And these people are on anti-epileptic drugs that are toxic and that can shoot your liver, shoot your kidneys, can cause sedation and cognitive impairment. And these patients are treated with these medications not knowing the correct diagnosis.
It sounds to me like you have just described a wonderful trial to undertake with CrowdMed. No, seriously, like if it can do that, if it could cut down the time to diagnosis for these diagnoses that require especially a clinical diagnosis, I mean, maybe it is worth it. Maybe it is better than the alternative.
And we didn't even get into it, but crowdsourcing also has a utilization in collecting data for research purposes. It's helpful for sharing information about the utility of medicines, and it's got numerous other clinical applications. If it's used appropriately, crowdsourcing can prove to be a life-altering advantage in this open data movement. Or if it's used carelessly, it could devastate you. In a world of digital doctors, I think that patient-centered care can thrive so long as patients and providers continue to respect each other and engage in a collaborative effort to solve problems. I know that sounds really cheesy, it's horrible, but I'm serious. I think that, these days, when you're trying to find information, and like Dr. Doe said, when you're desperate for finding an answer, you've got to be able to rely on these credible sources, and you've got to speak with your doctor about these alternative explanations for what you may be experiencing. Medical care is a collaboration, just like crowdsourcing. So think about that the next time you see your doctor. Alright, that wraps it up for BrainWaves this week. For more information on crowdsourcing in medicine, check out our post on brainwaves.me and subscribe to our weekly blog. Let us know what you think about our show by rating us on iTunes or whatever other podcast app you're using. You can also follow us on Twitter at BrainWaves Audio or Facebook at facebook.com/BrainWavesPodcast. You should also check out Dr. Rodman's podcast, Bedside Rounds. It's really kind of cool. It gives you a good flavor of the history of medicine and kind of where we've been and where we're going. You can find his podcast also on iTunes, so I definitely recommend you check it out. The episode this week was produced by me with the help of Adam Rodman and David Doe.
Our musical guests included Steve Combs, Lee Rosevere, and Julie Maxwell.
I'm Jim Sigler. Talk to you next time.